Welcome to the Deep Dive, where we crack open the most complex technical blueprints so you don't have to. Today, we are undertaking a systematic, well, almost forensic investigation into the traumatized knee.
Yeah, forensic is a good word for it.
We're moving beyond just the basic checklist approach. We're diving into how high-fidelity imaging, specifically, the non-contrast MRI, lets us essentially reverse engineer the moment of injury.
Right. It helps us identify the precise mechanism of failure and ultimately write that definitive orthopedic blueprint for treatment.
Exactly. Blueprint. I like that.
And for those of us navigating acute sports trauma, or any new trauma really, the MRI isn't just another diagnostic tool. It's the cornerstone of our clinical decision-making. It's the standard of care for a very good reason.
Right.
When a patient presents with a clinically unstable knee, the huge advantage of non-contrast MRI is its ability to delineate not just the severity of, say, the cruciate tears, is it partial, high grade, a complete blowout, but also to map out all the coexisting issues.
And that second point is so critical, isn't it? You're not just confirming what you suspect clinically, you're mapping the blast radius, so to speak.
Exactly. Knowing that full constellation of injuries, especially subtle things like maybe posterolateral corner instability or those peripheral meniscal ramp lesions, that's what guides our surgical approach.
And crucially.
And more importantly, it often prevents an unnecessary arthroscopy.
Yeah.
In cases where maybe a high-grade sprain could be managed non-operatively. Or conversely, it prevents us from missing a severe secondary injury that could basically doom a primary repair down the line.
Yeah, you don't want that ACL graft failing because you missed a PLC injury.
Precisely.
So our mission for you, the listener, today, if you're looking to gain speed and insight reading these studies, is to really adopt this mechanism-based diagnostic approach. We're looking at the imaging footprint and synthesizing it into a cohesive story.
It's not just listing structures, it's confirming the physics of the trauma.
Makes sense.
And if you aren't systematic, you will miss crucial details. Acute trauma leaves specific calling cards, especially in the osseous architecture, the bone bruises.
The fingerprints.
Exactly. We have to review the knee compartment by compartment. Osseous, then ligamentous, then cartilaginous. But, and this is key, this review has to be filtered.
How so?
We need to actively distinguish the findings of acute trauma like that bright, high T2 signal subchondral edema from chronic degenerative lesions that might just be, ambient noise in a middle-aged knee.
Yeah.
They might be irrelevant to the acute event.
You're separating the signal from the noise.
If you adopt the mechanism-based approach, you stop just looking at pictures and you start reading the patient's full story, the why behind the what.
Okay, let's start at the beginning then. The star player in sports trauma. The ACL. The anatomy here is absolutely everything. We know the ACL takes that steep oblique course running from the intercondylar notch of the lateral femoral condyle down to the anteromedial aspect of the tibial plateau. And our sources note this critical mean sagittal angle, 54 to 55.5 degrees. That specific obliquity.
That obliquity is the key to its function. It's not just trivia. If you look at a poorly placed ACL graft on a post-op scan and it looks too vertical, say, 70 or 80 degrees,
There's a problem.
you immediately know that graft is functionally compromised. It loses its ability to maintain tension properly throughout the full range of motion. It might act like a static restraint in deep flexion, but it offers almost no rotational stability or control near terminal extension. It's just not doing the job.
And let's highlight a technical detail that often trips people up. Its relationship with the joint fluid. The ACL is technically intra-articular.
Right, it's inside the capsule.
But it's fundamentally extrasynovial. It's got its own little wrapper.
It's wrapped in a protective layer of synovium. And that's the essential insight that explains the immediate, severe presentation of an ACL tear, why it swells up so fast.
Okay.
The ACL maintains its blood supply, its paraligamentous arterial plexus, within that synovial sheath. So when the ligament tears violently, and it's usually a high-energy event, it ruptures that plexus.
And all that blood pours out.
Exactly. That massive, painful swelling you see within minutes, that immediate catastrophic hemarthrosis, that's blood. It's an unmistakable sign of an acute, high-energy intra-articular injury. It screams ACL until proven otherwise.
Okay, moving to its internal structure, we have to respect the duality, right? It's not just a single cable.
No, definitely not. It's two functionally distinct bundles. We've got the longer anteromedial bundle, the AMB, clocking in around 34 to almost 40 millimeters, and then the shorter posterolateral bundle, the PLB, about 18 to 23 millimeters. The names come from where they insert on the tibia.
IMB and PLB.
And we treat them like a sophisticated biomechanical seesaw. They maintain reciprocal tension.
Ah, the seesaw analogy. I like that.
Yeah, it helps visualize it. It's why the knee feels stable through its whole arc of motion. When one bundle is taut, the other is relatively lax. This ensures consistent restraint without creating, excessive joint compression or binding.
Okay, let's lay out that tension pattern.
Okay.
It's crucial for surgical planning and for correlating with the physical exam findings. So, inflection.
In flexion, the AMB is taut. That's the workhorse against straight anterior tibial translation. The PLB, meanwhile, is relatively lax.
Got it. AMB taut inflection.
But as the knee moves into extension, the roles reverse.
Mm-hmm.
The PLB takes over and becomes taut, while the AMB slackens off a bit.
And the PLB is key for?
The PLB is pivotal for rotational stability and for achieving terminal extension, that final locking mechanism of the knee. It's the main rotational restraint. And arguably, that's the function that athletes miss the most after a traditional single-bundle ACL reconstruction that doesn't adequately respect the PLB's footprint or function.
That makes sense. Rotational control is everything in cutting sports.
Absolutely.
And this whole biomechanics lesson maps directly onto how we assess the knee clinically.
Precisely. We test these two bundles based on where they are maximally tension in the range of motion. So when we perform the anterior drawer test at 90 degrees of flexion,
We're pulling forward on the tibia.
yeah, and we're primarily testing the integrity of that maximally taut AMB. We're checking pure anterior translation resistance. How much does the tibia slide forward?
But if we suspect that critical rotational instability, the kind athletes hate,
Then we shift to the Lachman test and the pivot shift maneuver, which are performed closer to full extension, maybe 20-30 degrees of flexion. These tests are primarily identifying deficiencies in the PLB.
because the PLB is taut near extension.
Exactly. The pivot shift phenomenon itself, that horrible clunking subluxation of the tibia rotating and sliding forward over the femur as you bring the knee from extension into flexion with a valgus stress, that is the gross failure of the PLB to provide rotational stability. It's a very specific finding.
And that synergy between the clinical exam and the imaging.
Mhm.
That's why we're doing this deep dive, right?
That's the whole game. On the MRI, the normal ACL should show up as a nice, homogeneously low signal intensity band dark on T1 and T2. Ideally, it should run parallel to the intercondylar roof, a line we visualize on sagittal views called the Blumensaat line.
Okay, the Blumensaat line. Got it. Now, here's the classic diagnostic pitfall for the learner, the resident on call.
Oh, yeah. This one gets people all the time.
If you look distally near the tibial insertion, the source material notes a normal striated appearance. It looks a bit messy.
It does. This is just the ACL's distal insertion site being normally interspersed with small amounts of fat and synovium. It gives it this heterogeneous, almost frayed look.
But it's normal.
It's completely normal, but it's the classic trap. A junior resident sees that distal striated look and immediately worries about a partial tear, which would be a significant overcall in most cases.
So how do we distinguish that normal striation, which is just anatomy, from a genuine low-grade minor tear, especially since we know imaging uncertainty for partial tears is already notoriously high?
Right, it can be tricky. We have to rely on secondary signs, the clinical context, and really looking at the signal within the fibers. A true minor tear, especially in an acute setting, will usually show diffuse high T2 signal intensity actually permeating the ligament fibers themselves. That indicates hemorrhage and edema within the substance.
Not just around it.
Not just around it. Whereas the normal striated pattern is just pockets of fat between intact low signal fibers. That fat should remain relatively bright on T1 and follow fat signal on other sequences. In the normal knee, the ligament fibers themselves should maintain their crisp, black, low T2 signal intensity, even if the surrounding soft tissue is bright with fluid.
So the key is the signal within the fibers.
The moment you lose that crisp, low signal continuity and see amorphous, high signal infiltration within the ligament's course, you're likely looking at pathology, not just normal anatomy.
Okay, so once we identify pathology, we need to classify it. While partial tears make up less than a third of the cases, maybe around 15–20% in some series, their diagnosis is often challenging. We categorize them as minor, just a few fibers, low grade, less than 50% thickness, or high grade, 51% or more thickness involved.
And at high-grade partial tear, 51% or more.
Yeah.
That's where the imaging gets really messy, right? The difficulty is often visualizing those subtle distal tears near the tibial insertion.
It is. If you have a high-grade tear, you're often reliant on finding that diffuse high signal intensity, the footprint of edema and hemorrhage, within a ligament that should be uniformly black. If the ligament maintains its overall course, but it's just swollen and gray instead of black.
That's your high-grade sprain or high-grade partial tear.
Exactly. Functionally, it might be just as unstable as a complete tear sometimes. But for the majority, the 80% that are complete tears, the signs are usually much more direct and, frankly, unequivocal.
Oh yeah, usually pretty obvious. We're looking for clear ligament discontinuity. The replacement of that normal dark structure with amorphous, bright, high signal on fluid-sensitive sequences.
And the course.
And most vividly, the abnormal course. The ligament fibers will be wavy, maybe lying horizontally in the notch, or even completely balled up like a broken slinky in the intercondylar notch.
Aha, the slinky sign.
Yeah, seeing that confirms the total loss of mechanical integrity. The spring is sprung.
So that's the primary diagnosis. But where the MRI truly becomes functional, beyond just confirming the tear, is in demonstrating the mechanical consequence of that failure, what we call the secondary signs of ACL rupture.
Yes. This is effectively the imaging analog of a positive physical exam. It shows the effect of the ligament being gone.
This is the MRI anterior drawer.
Precisely. ACL incompetence allows the tibia to subluxate or slide forward relative to the femur. We measure this anterior translation on the sagittal plane, usually on the lateral side. This is a critical metric for grading the functional loss.
And the numbers here are highly specific, aren't they?
Very specific. If we see 5 millimeters or more of anterior tibial subluxation relative to the posterior cortex of the lateral femoral condyle,
5 millimeters.
we have a high specificity, around 93%, for ACL disruption. If that measurement hits 7 millimeters or greater,
7 millimeters.
we are at 100% specificity. That 7 millimeter mark is basically the point of no return. It tells us unequivocally that the primary restraint is gone, regardless of how torn up or maybe even partially intact the stump of the ligament looks.
The 5 millimeters is bad, 7 millimeters catastrophic failure.
Essentially, yeah. A 5 millimeter subluxation suggests clinically significant laxity, often requiring surgical intervention. But that 7 millimeter measurement represents gross mechanical failure. It means the secondary restraints, things like the menisci, the posterior capsule, even the PCL to some extent, are now all being grossly overloaded and stressed.
Are there other visual secondary signs besides the measurement?
Absolutely. The PCL, the primary posterior stabilizer, will often be visibly compressed, buckled, or indented from the tibia sliding forward underneath it.
It gets kinked.
It gets kinked, exactly. We also look for uncovering of the posterior horn of the lateral meniscus. Normally it sits tucked under the femoral condyle, but with ACL failure, the tibia slides forward, pulling the meniscus with it, leaving the back part of the condyle uncovered. These signs all point towards functional ACL absence.
Okay, let's connect these failures back to the kinematics, the injury mechanisms. The primary mechanism we usually associate with the classic ACL tear involves internal rotation of the femur relative to a fixed tibia during rapid deceleration or rotation.
Right. Think of a skier planting a ski edge hard and their body keeps rotating over it. Or a basketball player landing awkwardly from a jump and cutting sharply.
That valgus collapse plus rotation.
That mechanism leads us directly to the classic pivot shift event. This is often a non-contact injury, which seems counterintuitive, but it's very common. A valgus force, the knee buckling inward, combines with that internal tibial rotation or external femoral rotation, depending on your frame of reference.
And that combination can.
That force combination can create the infamous O'Donoghue unhappy triad, tearing the ACL, the MCL, and the medial meniscus all at once. And this specific dynamic failure leaves a very precise osseous footprint, those bone bruises, which we'll definitely drill into next.
Okay, but it's not always rotation, right? What about hyperextension?
Good point. Hyperextension is a different beast. This is usually a straight line force, like landing hard on a straight leg, or a martial artist throwing a kick that gets blocked and forced backwards.
So the knee bends the wrong way.
Exactly. In hyperextension, the femur and tibia essentially smash into each other anteriorly. You get a characteristic kissing contusion pattern.
Kissing contusion.
Yeah, impaction edema on the anterior tibial plateau, right up against matching edema on the anterior femoral condyle. This mechanism puts straight-line tensile stress on both cruciates and often the posterior joint capsule, too. Sometimes you can tear both the ACL and PCL simultaneously this way.
And the key differentiator from pivot shift is the location of the bruises.
Right. The absence of significant lateral or medial compartment contusions helps differentiate this straight hyperextension mechanism from a rotational pivot shift, which classically bruises the lateral side.
Got it. And finally, the clip injury, the direct contact, valgus stress, like a football tackle from the side.
Yeah, the classic linebacker hitting the running back low and from the outside. This creates a dominant acute impaction contusion, usually quite large, on the lateral femoral condyle where the direct blow occurs.
Okay, lateral condyle impact.
But the critical subtle finding is often the smaller focus of edema you might see on the medial side. This represents the avulsive force, the tension, ripping the MCL fibers off their femoral attachment as the knee is forced into valgus.
Ah, so the lateral bruise is the hit, the medial bruise is the stretch injury.
Exactly. Seeing that pattern, big lateral bruise, maybe smaller medial bruise, immediately mandates a dedicated search for a grade 2 or a grade 3 MCL injury. The contusion pattern tells you the direction and nature of the force vector.
Okay, this brings us perfectly to the bone contusions themselves. If we treat the MRI as that forensic tool, the bone contusion is the physical evidence left at the scene of the crime, so to speak.
It really is. You absolutely have to rely on your T2 fat-saturated sequences or STIR images, where that subchondral edema and hemorrhage just light up like a flare against the dark suppressed fat.
They really pop.
They do. And Sanders and colleagues defined 5 dominant patterns. Understanding these is like having the master key to unlock the mechanism-based diagnosis.
These patterns guide the search.
Totally. These contusions are pretty non-specific on their own, right? Bone edema just means bone got hit, but when you see them in a specific constellation, they dictate your search pattern for the soft tissue injuries. When we see a certain contusion pattern, we're immediately calculating the likely force vector and predicting the expected ligament and meniscal damage.
All right, let's start with the most common and arguably the most important one. The pivot shift injury pattern. This is the absolute hallmark of an acute ACL tear, the result of that rotational subluxation we talked about.
This is the one you have to know cold. We're looking for high T2 signal edema, that bright signal, in 2 very precise locations. First, the posterolateral tibial plateau. Think about the mechanics. The tibia slides forward and rotates internally, then slams back into place or impacts during the rotation. That posterior lateral corner takes the hit.
Posterolateral tibia. Check. And the second spot.
The second spot is the terminal sulcus of the lateral femoral condyle. This is that mid-portion of the weight-bearing surface of the lateral condyle. Think of it as a small, focused train wreck in the lateral compartment.
Train wreck.
Yeah, when the ACL fails, the lateral compartment, which is inherently a bit looser jointed than the medial side, rapidly translates and rotates, causing this impaction. The posterolateral tibia strikes the anterior aspect or mid-portion of the lateral femoral condyle, like we see in Figure 8.1 in the source material.
Okay, so that specific pattern, posterolateral tibia and lateral femoral terminal sulcus, that must trigger the immediate diagnosis of an acute ACL tear, or at least recent ACL incompetence.
Yes, even if the ligament itself is really swollen and hard to see clearly, that bone bruise pattern is incredibly sensitive and specific for ACL failure having occurred. It's the smoking gun.
And seeing this pattern also raises the risk profile for other things.
Absolutely. We immediately anticipate potential posterolateral corner PLC injury, often a sprain of the popliteal fibular ligament or the FCL itself. And we must meticulously search the posteromedial periphery of the medial meniscus.
Why the medial meniscus?
Because about 20% of these acute pivot shift ACL tears are associated with peripheral meniscal tears back there, often called ramp lesions. These happen due to the shear and rotational forces applied to the meniscus attachment during that violent subluxation event. You have to look carefully for them.
Got it. Pattern dictates the secondary search. Moving on, we have the unmistakable Seguin fracture. Tiny but mighty.
That's a great description. It is tiny, often just a fleck of bone, seen best on plain films or maybe the coronal MRI views, right at the lateral aspect of the lateral tibial rim, just below the joint line.
And the mechanism.
It's caused by internal rotation of the tibia with varus stress, so the opposite rotation of the pivot shift, avulsing the attachment of the iliotibial band, ITB, or sometimes the anterior oblique band, AOB, of the lateral collateral ligament complex.
And the clinical significance.
While it's relatively rare, maybe seen in only 5–10% of ACL tears, if you do see a second fracture on a plain film or MRI, Your likelihood of having an associated ACL injury jumps dramatically, somewhere between 75% to nearly 100%. It's a literal anatomical red flag waving at you saying, check the ACL.
Okay, high specificity.
Yeah.
Next up, a completely different force vector. The dashboard injury. High energy, straight impact.
Right. Classically from a motor vehicle accident where the knee hits the dashboard. But any direct, forceful blow to the flexed knee hitting the anterior tibia.
And the bruise pattern reflects that.
Exactly. The resulting contusion pattern involves the anterior tibia where the impact occurred, and often a corresponding bruise on the posterior subchondral patella as it gets driven back against the femur.
And this pattern screams.
PCL. This is the classic mechanism for posterior cruciate ligament injury. When you see this anterior tibia-posterior patella bruise pattern, your entire diagnostic focus has to shift posteriorly. You expect PCL disruption, maybe associated damage to the posterior joint capsule. You're no longer thinking primarily about rotational instability. You're looking for evidence of straight posterior tibial displacement.
Okay, mechanism dictates the search again. The final key pattern, and one that's often missed clinically because it's transient, is lateral patellar dislocation.
Yeah, this one is sneaky. The sources note that almost half, maybe even up to 3/4 of these are clinically unsuspected. The patella dislocates laterally, pops out of the groove, and then often immediately self-reduces as the knee extends, sometimes before the patient even fully registers what happened, especially if it wasn't a huge amount of force.
But the imaging footprint is there.
The imaging footprint is often permanent and absolutely critical for predicting long-term stability issues. The telltale contusions are found at the lateral non-articular portion of the lateral femoral condyle and the medial patellar facet.
So the medial patella hits the lateral condyle during relocation?
Exactly. As the patella snaps back into the trochlear groove, the medial facet impacts the lateral condyle. Seeing that specific bone bruise pattern medial patella, lateral condyle, maybe some joint effusion is almost pathognomonic.
And if you miss this pattern,
If you miss this pattern, you miss the crucial associated soft tissue pathology. You're looking for disruption of the medial patellar retinaculum and, most importantly, tearing of the medial patellofemoral ligament, MPFL. That's the main ligamentous check ring preventing lateral dislocation.
and if the MPFL is torn,
If the MPFL is torn and doesn't heal properly, the patient is at extremely high risk for recurrent patellar instability. So if you see this specific bone bruise pattern medial patella, lateral condyle, it is a non-negotiable instruction from the imaging to specifically evaluate the integrity of the MPFL fibers, which otherwise might just get lost in the noise of general medial knee edema.
makes perfect sense. Find the bruise, find the ligament tear.
Exactly. And don't forget to look closely for cartilage damage. That violent impaction and relocation can shear off a piece of articular cartilage from either the patella or the condyle. That fragment can then become an intra-articular loose body, causing locking and catching symptoms down the line. The contusion pattern tells you where to look for that potential loose body.
Okay, let's shift our attention posteriorly now to the posterior cruciate ligament, PCL. The big, strong, often forgotten stabilizer against posterior translation.
The forgotten giant, yeah. Unlike the ACL, it's usually best evaluated on sagittal T2-weighted images. It typically appears thicker, more robust, and maybe less prone to some of the subtle signal ambiguities we sometimes see in the ACL. Just a nice, thick, dark band curving down behind the tibia.
And its biomechanics are kind of the inverse of the ACL, which definitely trips up learners.
It really does. The anterolateral bundle of the PCL is the main workhorse, and it's taut in flexion. The posteromedial bundle is smaller and taut in extension.
So opposite of the ACL's AMB-PLB pattern.
Exactly opposite.
Yeah.
It makes sense biomechanically, though. The PCL is fighting against the tibia sliding backward. That force vector is maximized when the knee is flexed, like when you fall directly onto your shin, or in that dashboard injury mechanism.
Which links to the clinical test.
Right. The posterior drawer test, performed at 90 degrees of flexion, specifically assesses the integrity of that taut anterolateral bundle. How much does the tibia sag or translate posteriorly?
PCL injuries are less common overall than ACL tears.
Generally, yes, often resulting from higher energy trauma. The stats cited are around 45% from motor vehicle accidents, maybe 40% from specific sports mechanisms, like that direct fall onto the flexed knee.
And the tear patterns.
We often see partial tears or intrasubstance tears, commonly involving that main anterolateral bundle. It might look thickened and gray rather than sharply torn.
What about osseous injuries associated with the PCL?
The most frequent is a straightforward avulsion fracture right at the tibial attachment. The PCL is so strong it just rips off a piece of bone from the back of the tibia. You'll see that fragment displaced posteriorly.
Pretty clear when you see it.
Yeah, but structurally there is another specific high-yield, though rare, finding to hunt for, the reverse second fracture.
Ah, the counterpart to the lateral second.
Kind of. It's an avulsion fracture, but this time it's at the anteromedial aspect of the medial tibial plateau. It represents an avulsion of the deep portion of the MCL or possibly the meniscotibial ligament attachment back there.
And its significance.
While rare, if you see that reverse second fragment, it is highly specific for a significant posterior or posteromedial injury complex, almost certainly involving a PCL tear. It's another one of those small signs with big implications.
Now, here's a major diagnostic challenge that really separates the PCL from the ACL, especially in terms of relying solely on imaging. The PCL's apparent ability to scar in.
This is a huge potential pitfall, especially with chronic injuries. The source notes that PCL tears, even complete disruptions, may actually normalize in appearance on follow-up MRI scans over time. The ligament looks structurally intact, maybe a bit thickened, low signal.
Yeah.
But functionally, it can still be incompetent.
So the image looks good, but the knee is still unstable.
Exactly. The PCL is inherently thicker and has a better blood supply than the ACL. It often heals, but it heals with scar tissue. That scar tissue can maintain the bulk and the low signal intensity on MRI, giving you this false sense of security.
So morphology doesn't equal function for the PCL.
Not nearly as reliably as for the ACL. An ACL that looks bad is functionally bad. A PCL that looks acceptable, especially months or years after injury, may still be functionally incompetent because that scarred tissue simply lacks the proper stiffness and tension characteristics of the native ligament.
So the bottom line is?
The bottom line is that the MRI appearance of the PCL, especially chronically, does not correlate well with long-term functional dysfunction. The physical exam assessing the degree of posterior sag, the quality of the endpoint on the posterior drawer test remains paramount for treatment planning for the PCL. The image tells us if it tore, the clinical exam tells us if it still works.
That's a critical distinction.
Yeah.
Let's look at the surgical consequences then, which are deeply informed by imaging and these biomechanical issues. If PCL reconstruction is required, often reserved for high-grade tears, especially in multi-ligament injuries or young active patients with instability.
Right. Isolated PCL tears are often managed non-operatively first.
Then the traditional arthroscopic transtibial tunnel fixation method has a well-known critical flaw, sometimes called the killer turn.
The infamous killer turn, yes. This is a notorious potential failure mechanism for PCL grafts placed via the transtibial tunnel technique. Imagine trying to pull a thick, relatively rigid rope, like an Achilles tendon allograft maybe, around an extremely sharp corner under high tension.
Doesn't sound good for the rope.
It isn't.
Yeah.
In the traditional method, the graft has to exit the bone tunnel drilled through the tibia from anterior to posterior, and then make an acute, almost 90-degree turn upwards to reach its proper femoral attachment site in the medial femoral condyle.
And that sharp angle, right where the graft exits the bone tunnel.
That sharp angle creates immense friction and abrasive wear on the graft fibers, especially during knee flexion when the graft is under tension. It acts like a sawhorse, rubbing against the graft over thousands and thousands of cycles.
Leading to fraying and failure.
It can lead to late graft attrition, gradual stretching, loosening, and eventual failure. This acute turn makes the transtibial technique biomechanically, well, less than ideal for the PCL. The graft is stressed right at that critical turn the moment the knee flexes.
So what's the surgical response to try and circumvent this problem?
The surgical alternative is the tibial inlay procedure.
Deal in okay.
The inlay technique is designed specifically to eliminate that killer turn failure point. Instead of routing the graft through a transtibial tunnel, the surgeon makes a trough or inlay directly on the posterior cortex of the proximal tibia, right at the PCL's native footprint. The bone plug of the graft, like from an Achilles or patellar tendon allograft, is then fixed directly into that trough.
So it avoids the sharp turn completely.
Completely. It allows for a much smoother, more anatomic, non-abrasive path for the graft as it runs up to the femur. While it's technically more demanding, it often requires a separate posterior surgical approach to access and fix that bone plug. It ensures a more biomechanically sound reconstruction, eliminating the killer turn stress riser and theoretically improving long-term graft survival. It's a superior, though definitely more complex, engineering solution.
Okay. Moving beyond the cruciates. As we mentioned, complex trauma rarely happens in isolation. We have to systematically check the rest of the joint structures. Starting medially, The medial collateral ligament, MCL.
Yeah.
Probably the most frequently injured ligament of the knee overall.
Yeah, very common. Typically injured via a valgus stress to a slightly flexed knee, that classic clipping injury again, or just landing awkwardly with the knee buckling inwards.
And we rely on the standard I3 grading system.
Yep, pretty straightforward. Usually best evaluated on the coronal plane T2 fat-saturated or SDR images. Grade 1 is the mildest. The ligament fibers themselves are intact, maybe slightly thickened, but the main finding is high signal edema and hemorrhage in the soft tissue surrounding the ligament. Clinically, this corresponds to pain, but a firm endpoint on valgus stress testing.
And we have to be a bit careful with interpreting just edema medially right. There are mimickers.
That's a really important point. Localized edema around the medial knee, especially near the MCL origin or insertion, might also be caused by something like a ruptured Baker cyst tracking fluid down, or crucially, edema tracking over from a recent lateral patellar dislocation event. The patellar dislocation edema can be quite extensive medially due to the MPFL tearing.
So you need the whole picture.
You need the whole picture. Don't just call an MCL sprain based on medial edema alone if the fibers look intact. Check the patella. Check the popliteal fossa.
Okay, grade 2 is a partial tear.
Partial tear, more significant fiber disruption, maybe some laxity clinically. Grade 3 is complete disruption, either through the mid-substance of the ligament or an avulsion from the femoral or tibial attachment site. The ligament fibers are clearly separated, often wavy or retracted, and the edema is usually extensive. There's gross valgus instability clinically.
And if you see a grade 3 MCL tear.
You must search diligently for associated ACL injury, maybe 50–70% association, and also look carefully for meniscal injury, particularly medial meniscus tears. It's often part of that unhappy triad constellation.
Right. Now moving to the lateral side, the posterolateral corner, PLC injuries. These are often described as the quiet killer of knee stability.
They really can be. They are notoriously occult clinically, meaning hard to diagnose definitively just by physical exam unless they're grossly unstable. But if left untreated, even moderate PLC instability is a major risk factor for subsequent ACL graft failure down the road. The ACL graft just gets overloaded because the back corner support is gone.
It's a complex area anatomically.
Very complex. It's a web involving the main static stabilizers like the fibular collateral ligament, FCL, or the LCL proper, the popliteal fibular ligament, the arcuate ligament complex, and also dynamic stabilizers like the popliteus muscle and tendon unit.
How do we assess it on MRI?
An isolated grade 3 FCL tear is usually pretty obvious, clear mid-substance disruption or avulsion of that distinct cord-like ligament running from the femur to the fibular head. But often the more subtle PLC sprains involving the other structures are the ones that get missed.
This brings us to a critical diagnostic pearl mentioned in the sources, the popliteus window.
Ah, yes, the popliteus window. This is a great sign to look for. If you see strain, that focal high T2 signal edema extending along the muscle fibers right at the proximal myotendinous junction of the popliteus muscle, where the muscle belly transitions into tendon behind the lateral femoral condyle,
That signals trouble.
that signals that major stress has been applied to the PLC. The popliteus muscle is a key dynamic restraint back there. If it's showing signs of injury, it strongly suggests that the primary static restraints, like the popliteal fibular ligament and maybe the FCL itself, have likely been significantly overloaded and potentially injured as well, even if they look okay.
So it's an indirect sign of deeper injury.
It's our imaging window into potential occult PLC instability. Missing that popliteus strain signal means you might be missing a clinically relevant instability that absolutely needs to be addressed, often concurrently with an ACL reconstruction to prevent failure.
Okay, let's shift our view anteriorly now to the extensor mechanism, quadriceps and patellar tendons.
Right. Quadriceps tendon tears are often seen in slightly older recreational athletes, maybe the weekend warrior type. Usually happens during forceful contraction like jumping or sprinting. We assess them on sagittal images, looking for signal alteration, thickening, fiber discontinuity, and crucially measuring any gap or retraction if it's a full tear.
And below the patella, the patellar tendon. Overuse is the big enemy here.
Overuse is the main culprit. Patellar tendinopathy, often called jumper's knee, is super common in jumping sports athletes. It presents on MRI as thickening and increased T2 signal, usually right at the proximal end, near the inferior pole of the patella where the stress concentrates.
Is there a rule of thumb for thickness?
A quick rule of thumb for the learner. The normal patellar tendon should always appear thinner than the quadriceps tendon measured just above the patella on the same sagittal slice. If the patellar tendon looks equal in thickness or even thicker than the quad tendon, you've likely got tendinopathy.
Useful tip.
Yeah.
And in skeletally immature patients, the growth plates are vulnerable.
Exactly. Repetitive microtrauma from jumping and running leads to the specific avulsive syndromes or traction epiphysiotides. We need to differentiate Osgood-Schlatter disease, which affects the distal patellar tendon insertion onto the tibial tuberosity. You see fragmentation and swelling there.
Right, the bump below the knee.
From Sinning-Larsen-Johansson SLJ syndrome, which involves the proximal patellar tendon attachment at the inferior pole of the patella itself. You'll see edema and sometimes fragmentation right at the bottom tip of the patella. Both are painful conditions related to overuse during growth spurts.
Got it. Finally, we need to touch on the synovium and plicae, the joint lining.
Right. Normally, the synovium is incredibly thin, almost a potential space, so it's barely perceptible on standard MRI sequences. If you can see the synovium clearly as a distinct layer, it usually suggests pathology, either simple joint fluid distending the space or true synovial thickening and inflammation.
And if we suspect chronic inflammation, like in rheumatoid arthritis or pigmented villonodular synovitis, PVNS,
then we need contrast. Intravenous gadolinium contrast is really the only reliable way to differentiate enhancing vascularized proliferative synovium, which indicates true chronic inflammation or synovitis, from simple joint effusion fluid, which won't enhance significantly. Contrast helps characterize the synovial process.
Okay. And what about plicae, those folds?
Plicae are basically just leftover embryological folds of synovial tissue that persist into adulthood in many people. Most are asymptomatic, but the medial patellar plica is the one that's most often clinically relevant.
When does it become symptomatic?
It becomes symptomatic when chronic irritation or direct trauma causes it to thicken and lose its elasticity. It then starts to impinge or snap over the medial femoral condyle during knee flexion.
And there's a classification for this.
Yes, the Sakakibara classification helps grade the size and morphology. Types A and B are usually small, thin, and clinically insignificant. But types C and D, these are the large, thick, shelf-like prickle structures that drape over the interior surface of the medial femoral condyle.
Those are the bad actors.
Those are the ones most likely to be symptomatic. They physically get tinged between the medial femoral condyle and the patella during movement, causing anterior knee pain, clicking, and sometimes catching sensations. The radiologist needs to specifically comment on the plica's size and thickness if it looks like a type C or D to correlate with potential clinical symptoms of impingement. All right, shifting gears now to the post-operative knee. Evaluating a reconstructed knee is fundamentally different from looking at acute trauma. The first thing we absolutely need to know is what material was used for the graft.
Right, the implant details are key.
The two main autograft choices are BPTB, bone patellar tendon bone, taking the central third of the patellar tendon with bone plugs from the patella and tibia, or hamstring grafts, typically using the semitendinosus and gracilis tendons doubled or tripled up.
And the choice between them involves a significant clinical trade-off, doesn't it?
Absolutely. BPTB, using those bone plugs, provides excellent, strong early fixation. Bone-to-bone healing in the tunnels is generally very robust and predictable. This is often favored for high-demand athletes who need or want a potentially faster return to cutting and pivoting sports.
But there's a downside.
The big downside is the significant potential for harvest site morbidity, specifically anterior knee pain right over that patellar tendon harvest site. This can be quite bothersome and sometimes chronic. There's also a slightly higher risk of complications related to the extensor mechanism itself, like rarely patellar fracture during harvest, or later patellar tendon rupture, or just persistent patellofemoral pain and difficulty kneeling.
So the hamstring graft avoids that.
Mostly, yes. The hamstring graft, using tendons harvested from the medial thigh, minimizes that anterior knee pain issue. However, the fixation relies on soft tissue to bone healing within the tunnels, which requires different hardware, like interference screws, buttons, cross pins, and historically maybe had a slightly higher risk of loosening or graft slippage during the first few months of recovery as that healing occurs. Fixation techniques have improved dramatically, though.
Okay, so once the graft is in, the key interpretive concept we need to understand is the graft maturation timeline. Sometimes it's called ligamentization.
Yes, this is crucial for not overcalling problems.
Yeah.
The graft's appearance on MRI changes dramatically over the first year or so as it biologically transforms from being basically dead tendon bone composite into a living, functioning ligament-like structure.
Walk it through that timeline.
Okay. In the immediate post-op phase, maybe the first few weeks or couple of months, the graft usually looks great, homogeneous, low signal intensity, sharply defined, looks perfect.
Feels like a native ACL.
Pretty much. But this is where the teaching point lives. Between roughly 3 to 8 months post-operatively, the graft undergoes this intense process of remodeling and revascularization. It's getting new blood supply, cells are moving in, collagen is turning over.
Becoming alive again.
Becoming alive again. And during this phase, this kind of biological puberty, the graft typically shows intermediate or even slightly increased signal intensity on both T1 and T2 weighted images. It looks gray instead of black. This is normal.
Okay, so gray signal between 3 and 8 months is expected.
It's expected and usually represents normal maturation.
Sure.
This is probably the resident's second biggest trap after misinterpreting that normal distal ACL striation. Seeing this intermediate signal in a perfectly healthy remodeling graft at, say, 6 months post-op and calling it a partial tear or degeneration.
Big overcall potential.
Huge potential. You must be very cautious interpreting graft signal in that time frame. By 12 months and beyond, true ligamentization is generally considered complete. The signal should ideally stabilize and return towards the native low signal intensity of a healthy ligament.
So because that signal is so ambiguous in the first year,
Right, because signal alteration during that first year is so common and often normal, the sensitivity and specificity of MRI for detecting partial graft tears during this period is inherently quite poor. We can't reliably rely on signal alone.
so if signal is unreliable, especially early on, what are the more definitive signs of graft failure we should be looking for?
We have to focus more on the mechanical signs, the morphology. Obvious discontinuity or complete absence of the graft is, well, obvious failure, but more subtly, look for posterior bowing of the graft. A healthy graft should be taut, running straight between its tunnels. If it's sagging backwards significantly, that signals gross laxity, stretching, or complete mechanical failure.
Like a loose rope.
Like a loose rope instead of a tight cable. But perhaps the most specific sign, according to some studies, is a definite change in the graft's caliber. A graft that maintains a consistent, uniform caliber throughout its course has a very high specificity, maybe close to 100%, in excluding a full thickness tear.
So consistent thickness equals intact.
Pretty much. Conversely, seeing a distinct, localized thinning, or sometimes even a focal thickening or bulge within the graft's substance, that is highly suspicious for a full thickness tear, regardless of what the confusing intermediate signal might look like around it. Look for the shape change.
Okay, caliber change is key. Let's look at mechanical complications related to the surgical technique itself. Specifically, the dreaded loss of normal extension, often due to improper tunnel placement and impingement.
Yes, this is a major issue if the tunnels aren't placed anatomically. It often results from placing the tibial tunnel too far anteriorly on the tibial plateau.
Too far forward.
Too far forward. The ideal placement dictates that the ACL graft, when the knee is fully extended, must parallel but absolutely never contact the intercondylar roof, that Blumenstadt line we talked about earlier. There should be a clear space between the roof and the graft in full extension.
And when the tibial tunnel is placed too anteriorly,
When it's too anterior, the graft essentially gets squeezed or impinged directly between the femur and the tibia as the knee comes into terminal extension. This is called roof impingement. You can visualize this on sagittal MRI.
what does it look like on the image?
The MRI picture is often classic and directly shows the mechanical stress. You'll see increased signal intensity, that grayness again. But this time it's usually confined specifically to the distal 2/3 of the graft, right where the mechanical deflection and rubbing occur against the roof. Crucially, the graft itself will often show a visible angulation or bend where it hits the roof. It's not running straight anymore.
And the consequence.
This chronic mechanical stress is essentially grinding down the graft fibers over time, leading to fraying, partial tearing, and eventual complete graft failure. Clinically, it also causes a mechanical block to full extension, resulting in a restricted range of motion, specifically that frustrating loss of the last 5-10 degrees of extension, and often anterior knee pain.
Makes sense. What about other complications? Formation of scar tissue, arthrofibrosis?
Yes, excessive scar tissue formation can be a real problem, specifically the formation of a cyclops lesion. This is a distinct nodular mass of dense fibrous tissue that forms in the anterior aspect of the joint, right in front of the ACL graft, near the tibial tunnel entrance at the joint line.
Like a little scar ball.
Exactly. And because it's typically old, dense, fibrous scar tissue, it appears low signal intensity dark on both T1 and T2 weighted images. It just looks like a hard black lump sitting there.
And its functional effect.
Functionally, it acts just like roof impingement does. It creates a mechanical block. As the knee tries to extend fully, this cyclops lesion gets pinched between the femur and tibia, physically restricting those last few degrees of knee extension and often causing pain and sometimes locking or catching symptoms. It has to be surgically removed if symptomatic.
Okay. We also need to consider issues with the bone tunnels themselves, like tunnelitis or widening.
Right. The source material notes this often occurs within the initial 3 months post-op, but can progress. The bone around the graft fixation, especially within the tibial tunnel, can resorb or lease, leading to significant widening of the tunnel diameter compared to when it was drilled.
Why does that happen?
The etiology is probably multifactorial. It could be related to subtle graft motion within the tunnel before full healing occurs, the windshield wiper effect, maybe a biological reaction to the graft material or fixation device, or sometimes inadequate initial fixation allowing micromotion.
And the clinical relevance of tunnel widening.
The clinical relevance is major, especially if the patient re-tears their graft and needs revision surgery. If those tunnels are significantly enlarged, say more than 12-14 millimeters wide, we often can't perform a straightforward, single-stage revision ACL reconstruction. Because the enlarged tunnels provide poor fixation quality for the new graft, there's not enough good bone stock to securely hold the revision graft. In these cases, we usually have to proceed with a 2-stage revision procedure. First, we go in and bone graft the enlarged deficient tunnels to restore the bone stock. We let that heal for several months, maybe 6 or 9 months. Then, in a second surgery, we come back, re-drill new tunnels through the now consolidated bone graft, and place the revision ACL graft.
Wow, that's a significantly longer and more demanding recovery path for the patient.
Absolutely. So tunnel widening is a critical finding to report as it directly impacts future surgical planning.
Makes sense. And finally, a quick mechanical check. Hardware failure. The screws, buttons, pins.
Right. We always need to check the fixation hardware itself. Interference screws can sometimes back out or migrate, cross pins can break, suture buttons can flip or displace, staples can loosen.
And the consequence.
If hardware fails or significantly displaces, fragments can potentially migrate into the joint space, becoming intra-articular loose bodies that cause mechanical symptoms like locking, catching, or pain. We also need to check for any associated cartilage damage that might have been caused by prominent or loose hardware rubbing against the articular surfaces. The surgical hardware is part of the knee's blueprint now, and its position and integrity are critical to evaluate on follow-up imaging.
Okay, we have systematically dissected the complexity of the knee, structure by structure, injury by injury, complication by complication. But we absolutely must end with the synthesis, recognizing the full picture. Especially in high-energy trauma, we are rarely dealing with just an isolated injury. We have to recognize the patterns of multi-ligament knee injury, MLKI.
Absolutely. MLKI is really the preferred terminology now over the older term knee dislocation, especially when at least 2 major stabilizing structures, any combination of the cruciates or the collaterals, are significantly injured. Our final imaging report cannot, or at least should not, be just a simple checklist of findings. We need to shift our interpretation to provide a cohesive narrative summary that's driven by the likely mechanism.
So, for example, instead of just reporting ACL tear found, MCL sprain noted, bone bruises present, we should aim for something more synthesized.
Exactly. We should provide a conclusion like, constellation of MRI findings consistent with a recent high-energy pivot shift type injury mechanism at the right knee. This includes evidence of an acute mid-substance complete tear of the ACL, a likely high-grade SEC or the 3, involving the popliteal fibular ligament component of the posterolateral corner, and findings suspicious for a vertical tear at the posteromedial periphery of the medial meniscus, potentially representing a ramp lesion.
That narrative instantly tells a much clearer story to the treating surgeon.
It does. It explains the likely direction and magnitude of the applied biomechanical force. Recognizing these injury constellations, like the pivot shift pattern, which implies significant rotational failure, allows us to anticipate and actively look for those secondary injuries that are often occult-like, those posteromedial meniscal ramp lesions, which can be hard to see on standard MRI cuts, but are absolutely critical to identify and address during surgery to prevent early ACL graft failure.
The MRI provides unparalleled anatomical detail, especially its high sensitivity and specificity for recognizing complete ligament tears, which is crucial for guiding whether we proceed with non-operative management or surgical treatment.
It does. The anatomical detail is fantastic. That said, despite its fidelity, we must always return to that core limitation we discussed, particularly regarding the PCL.
Right, the morphology versus function issue.
The image only tells us what structure was injured and maybe how badly torn it looks anatomically. It can definitely mislead us, particularly in the case of a chronically scarred PCL that looks structurally healed and intact on MRI, but remains functionally lax and incompetent.
So the final provocative thought for the listener.
The gold standard remains the synergy. High-fidelity imaging tells us the detailed anatomy of the injury. The dedicated, skilled physical examination tells us about the functional instability, the laxity, the endpoint quality. We need both. The image might tell us what structure needs to be fixed or what was fixed. The patient's exam often tells us how well the system is actually holding up, whether the repair is working or when it failed. We must never confuse anatomical integrity on a static image with true functional stability in a dynamic, living patient.
That was truly an exceptional deep dive into the orthopedic blueprint of knee trauma. So many pearls there. Key takeaways for you, the listener. Really master the reciprocal tension biomechanics of the ACL's AMB and PLB and consciously link those directly to the physical exam tests like the drawer, Lachman, and pivot shift.
Know your bundles.
Know your bundles. Understand that the bone contusion patterns, pivot shift, dashboard, patellar dislocation are like the forensic evidence, the fingerprints, revealing the trauma mechanism and guiding your search for associated injuries.
Read the bruises.
Read the bruises. And finally, when looking at the postoperative knee, recognize that graft signal change between 3 to 8 months is often just normal biological puberty, not necessarily failure. Instead, hunt for those specific mechanical failure signs, like posterior bowing, critical changes in graft caliber, and evidence of impingement like the killer turn for the PCL or roof impingement for the ACL.
Focus on morphology and mechanics post-op, not just signal. If you can master the language of trauma as written on the MRI, you stop seeing just static pictures and you really start seeing the dynamic story of force vectors and failure mechanisms unfolding. That shift in perspective is the difference between just reporting findings and truly guiding effective treatment.
Couldn't have said it better myself. Thank you so much for sharing your expertise today, and thank you all for joining us for this extensive deep dive. If you have a complex technical blueprint you want us to crack open next time, please do let us know.